Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion is systemic hypertension. So before getting into the topic, we given the name of systemic hypertension. So roughly, usually we'll mention as a hypertension if you are taking blood pressure in with a sphygmomanometer or with a cuff or with an intra-arterial line means usually we'll use like a hypertension. But so hypertension is a broad term, like systemic hypertension is there. So systemic hypertension means where we are getting from the sphygmomanometer or your monitor, cardiac monitor, that is the systemic hypertension. If you are going in the cerebral region means that is a cerebral hypertension also there. If you are going into cardiovascular, your gastrointestinal system means there we have a portal hypertension. If you are going into your pulmonary means there we have a pulmonary hypertension. So there is so hypertension is a broad term. So when you are indicating your systemic hypertension means named as a systemic hypertension. If you are going with a pulmonary means based on that area we have to mention the which hypertension. So that is one of the important thing. So blood pressure, what is meant by blood pressure? So pressure of the blood is a blood pressure, right? Simple term. So pressure of the blood, so it is a force or pressure of the blood that is against your arterial wall. So it is happening because of your contractility, otherwise because of your pumping force of your heart, that is only creating that pressure. So the pressure of the blood against your arterial wall because of your pumping activity of your heart. So again, systemic hypertension means increase in the systemic blood pressure. So here we are categorizing into hypertension into two categories, primary and then secondary. Primary majorly causes unknown or idiopathic. Secondary means because of some other specific disease, it will cause the systemic hypertension. That is the secondary systemic hypertension. So based on American Heart Association, these are the range. Normal is less than 120 mmHg of systolic, diastolic is a less than 120, less than 80. Elevated means 120 to 129 of systolic and then diastolic of less than 80. So if the stage 1 hypertension means the range is 130 to 139 of systolic, diastolic is 80 to 89. Stage 2 means more than or equal to 140 of systolic, more than or equal to 90 of diastolic. Hypertension crisis means more than 180 of systolic, more than 120 of diastolic. These are the ranges. And then malignant hypertension is more than 200 of systolic, more than 140 of 140 of diastolic, 140 of diastolic with retinal hemorrhage and then papilloedema. Hypertensive urgency means marked elevated blood pressure without any end organ damage. So the range is more than 180 bar 120 mmHg. So 180 of systolic, 120 of diastolic millimeters in mercury. Here the markable word is without any end organ damage. End organ in the sense it denotes your brain, heart, lungs and then kidney. Those are the end organs, liver. So those are the end organ. If no changes or no damage in the end organ means that is a hypertensive urgency. Emergency in the sense the same range more than 180 120 millimeters of mercury blood pressure will be there in range, but with end organ damage means, so in heart means there will be changes in the any ischemic or acute coronary syndrome, ischemic changes will be there, myocardial infarction. So if it is a brain means end organ damage means brain, what will happen, there will be a your stroke related manifestation it will. So those are the things indicating the end organ damage or dysfunction. Then the fourth one is a white coat syndrome. So BP is highly elevated state, only it's recorded is the inside the hospital. So that is the not really hypertensive. And then pseudo hypertension means falsely elevated blood pressure, mostly in the elderly cases because of the stiffness of the arterial wall. And then paroxysmal hypertension means that is a paroxysmal in the sense that will be episode, like episodic elevation of BP seen in the pheochromocytoma. Pheochromocytoma means there is a tumor in the catecholamine secreting hormone. So catecholamines means we know adrenaline, noradrenaline secreting adrenal gland. So there will be a tumor in the catecholamine secreting hormone. Here what will happen means it will increase the production of adrenaline, noradrenaline, catecholamines. So causes like we told, primary is unknown or idiopathic cause. Second is due to damage in the any other organs like a kidney, arteries, heart, endocrine system. So renal means glomerulonephritis, systemic disease like diabetic mellitus, systemic lupus erythematosus, polycystic kidney disease, and then renal tumors. Endocrine in the sense Cushing syndrome, pheochromocytoma, Cohn's disease. Cushing syndrome means hypercortisolism. So the cortisol level will increase. Pheochromocytoma already we told. Cohn's disease means hyperaldosteronism. So and then hyperparathyroidism is another cause. Drug related sympathomimetic and then NSAID is corticosteroid. Other like alcohol, obesity, obstructive sleep apnea. So these are the some causes for the hypertension. So assessment wise, general impression, the person having a hypertension emergency appears sick. So hypertension emergency means the person have a marked elevation of BP with end organ dysfunction. So they appear sick, and then mental status wise, based on the range, it will the person will be responsive and then altered, some rather time unresponsive also. So circulation, here we can see the skin changes. So skin, what will see, CDC, condition, temperature, and then color of the skin. So color of the skin may be pale or flushed or normal in color, and then here you can see the temperature, dry or moist or warm or cool. So peripheral pulses wise, it may feel strong and then bounding pulses will be there. Patient blood pressure in both arms, we have to check in the case of aortic dissection. So aortic dissection means separation, right? So there will be a separation, layer separation in the aortic intimal layer. So innermost layer is intimal layer. There will be a separation. So if it is a normal layer means there will be a separation like that will form a pseudo layer. So, in the intimal layer, that is called aortic dissection. So in this case, what will happen means here we have to check the both side, means left upper limb and then right upper limb, both side we have to check the blood pressure. If it is a aortic dissection means there will be a BP difference of more than 20 mmHg in both arms. So we are taking blood pressure means in interarm BP difference is more than 20 mmHg means that denoting the aortic dissection. So further, these are the some clue factors, clinical examination related. Again, we have to go for the imaging and then we have to go for the further studies to confirm the diagnosis. So these are the some clinical signs related. So the person have a seizure, signs of heart failure, signs of consistent with the acute myocardial infarction. So we told no, if any end organ dysfunction like a seizure or your ACS, acute coronary syndrome, or your stroke related means that will shows the those features. And then ischemic changes will be there. We have to ask about the drug related history, any over the counter medication the person taking or not, or any sympathomimetics. And then these are the some common symptoms and signs. Majorly hypertension is a silent serial killer like a person. So it won't show any symptoms or any signs in the early stages. Once if any problem, otherwise once any damage occurs in the end organ means, then only it will reveal its real face, then only it will reveal the severity of the hypertension. Until unless the end organ damage, it won't show any signs and symptoms or clinical features. So if any end organ dysfunction happen means that will cause, based on the organ dysfunction, it will show the symptoms. Mainly dizziness, facial flushing, headache, fatigue, epistaxis, palpitation, chest pain, and then tinnitus, nervousness. So those are the some common symptoms. So signs wise, we can see the pedal edema, postural hypotension, high systolic diastolic blood pressure while recording, we can find hypertensive retinopathy, and then radiofemoral delay in the coarctation of aorta. That is most important. Coarctation of aorta means narrowing of the aorta. So your aorta will be like this only, no? So but coarctation means there will be a narrowing in the aorta, some portion that gets narrow. Mainly that will occur in the congenital cases, in the pediatric congenital anomalies. here we can feel the radiofemoral delay. Means if you are palpating simultaneously over the radial and peripheral, means there will be a there won't be a equal conduction. So if you are palpating in a normal human being, normal healthy individual, means we can feel the normal simultaneous conduction in the both pulses, both areas. But if you are going with the coarctation of iota, means there will be a delay. So radial first will occur first because it is originating before the coarctation of iota, before the narrowing portion. So it will occur first, and then some after time, some after 1 or 2 3 seconds within a delay, you will palpate the femoral pulse. So that is why you have to palpate radial and femoral mean the same time. If it is a coarctation of iota, there will be a delay in the femoral and radial pulse conduction. And then differential diagnosis wise, for cardiovascular, aortic dissection, genitourinary, pheochromocytoma, renal failure, toxemia, and then pregnancy. Neurological means epilepsy or post-ictal states. So post-ictal state, again we know, mainly in the case of seizure there will be 3 stages, right? Aura ictal, post-ictal. In post-ictal also it will come. Head injury, intracranial mass, stroke, subarachnoid hemorrhage, other causes like acute anxiety, cocaine or amphetamine usage. Amphetamine is one of the drug. So connective tissue disease like drug overdose or drug withdrawal syndrome. So assessment, like next is a management. So what is the thing we can do in the pre-hospital area? So again, management wise, the person won't call because of the hypertension. Though you might receive a call like acute coronary syndrome, like chest discomfort. The person will approach our emergency medical system with a complaints of chest discomfort or with the complaints of stroke related. That is what the will receive a call. So and then so once after getting into scene, if you are measuring the vital signs, there we can find out the hypertension. So hypertension uh, is the main culprit that is causing the chest discomfort or stroke. So here we have to treat that acute condition, like might be that might be acute coronary syndrome or that might be a stroke, that we have to treat. Mean the same times we have to treat that hypertension also. If you are forgetting about the hypertension, means again it will cause the same symptoms or some other symptoms. So we have a two entity, we have to treat that acute condition, mean the same time we have to treat that hypertension also. So for that, both treatment we can carry out in the pre-hospital region. Again, it will take some sort of time. We have to go for the lot of diagnosis, and then we need a further equipments that won't happen in the pre-hospital region. Here, what we can do. So if the person shows a symptom of acute coronary syndrome or ACS or your ischemic related, means based on your local protocol online medical direction, we can treat that condition, acute condition. Mean the same times to reduce the blood pressure, here we can go with some pharmacological treatment, that is the labetalol. So two condition, first we manage the acute condition based on the local protocol. For management of your hypertension, here we can go with some pharmacological agent that is called labetalol. So labetalol, it's a alpha and beta blocker, right? So to understand the pharmacodynamic of this drug, we have to remember the what is the alpha receptor do, what is the beta receptor do. So alpha receptor, where it will be in the vessel. So what will cause? It will cause the vasoconstriction, right? That is the normal action. So then beta, so beta means two major things are there, beta 1 and beta 2. Beta 1 in the heart. So we have a one heart, so beta 1 in the heart. So it will increase the force of contraction of heart, means it will cause the inotropic effect. So beta 2 in the sense that will be in the lungs. So it will cause the bronchodilation, means this is the normal physiology. So if the drug act in the alpha receptor, that is the alpha agonist, means it will cause the vasoconstriction. Beta blockers, beta receptor, beta 1 means if the drug act along with an beta 1, otherwise beta 1 agonist means that will cause the inotropic effect. Beta 2 agonist means that will cause the bronchodilation. So with this view, here we told alpha and beta blockers. So it will block the alpha and beta function. So if the drug blocks the alpha function, means what will happen? It will prevent the vasoconstriction. So it won't dilate the vascular, it will prevent the vascular constriction. So thereby the peripheral vascular resistance will reduce, so the BP automatically it will reduce. So that is the common. And then again beta blockers mainly will use in the case of it is a hypertension, one of the antihypertensive. Mean the same time here we told it is the beta 1 is a inotropic, force of contraction it will reduce. So if you given a beta blocker means it will reduce the heart rate. Mainly the beta blockers two major purpose, one is a antihypertensive, second is a it is a rate controlling drug. Okay. So if the person with a history of asthma and then COPD means that is a relatively contraindicated. In that cases, it beta blocker or labetalol is a relatively contraindicated, not absolutely contraindicated. Absolute limit, definitely we should not give the labetalol or beta blockers. Relatively means somewhat we can give, but we have to anticipate the like bronchoconstriction and then the heart rate will be reduced. Those are the some complications that we have to anticipate and then that we have to ready to treat. So that is the thing we have to remember. So that is why we kept as a relatively contraindicated, not absolutely contraindicated. And then the dose range wise 20 mg initial dose, and then if furtherly needed means we can go with an 40 to 80 mg every 10 minutes, and then the maximum dose is a 300 mg. So this is the management for the hypertension in pre-hospital region. So in other pharmacological therapies in hospital, what we are following diuretics and then drug acting on the renin angiotensin system, adrenergic receptor blockers, calcium channel blockers, and then vasodilators. These are the some other drugs what we are using in the inside hospital. And then this is the set of management in the hypertensive emergency, what we are doing in our ER emergency room. This is the some drugs like intravenous nitroglycerin, nitroprusside, labetalol, and then magnesium sulfate. These are the various dose ranges. And then some rather cases, if it is hypertensive urgency means without any end organ dysfunction. So mainly again it is in ER or in OP basis they will treat. In pre-hospital we won't get these are the calls. So here we are managing, there we are going with an every intravenous route. Here we'll manage with an through perioral route where we are treating. So mainly we are treating. So this again urgency they will treat in the OP basis or in ER basis. We won't get those are the calls in the pre-hospital region. So complication wise in cardiac means left ventricular hypertrophy, atherosclerosis, aortic dissection, and then atrial fibrillation. CNS wise stroke, hypertensive encephalopathy. Kidney wise it will cause the proteinuria. Eyes wise it will cause the complicated hypertensive retinopathy. These are the some complications of hypertensive emergency or hypertension. So do your best. Shalom.